All right, here we go. Welcome everybody on Facebook. We'll be posting to YouTube as well as Instagram once we get this recorded. But Dr. Brandon Money here, another episode of the top 5 golf swing related injuries. This is episode 5. Once again, Dr. Brandon Money here of the Centeno Schultz Clinic, world leader in interventional orthobiologics treatments. And so today on our episode, we're going to be focusing on the cervical spine, also known as the neck area. Very, very common. One of probably the top 3 areas in the body that I have patients that come in and that have issues associated with their neck. Number 1 is probably the knees. Number 2, lumbar spine. Number 3 is probably the neck, maybe the shoulder up there with the neck as well. But a little bit about me. If you've seen these before, you know what's going on. Dr. Brandon Money here. I'm board certified in physical medicine and rehabilitation. I'm also fellowship trained in interventional orthopedics here at the Centeno Schultz Clinic, and stayed on as an attending physician afterward, because where else would you want to be? I'm also certified by the Titleist Performance Institute, which is a network of golf professionals, teaching professionals, physical therapists, chiropractors, physicians, and other experts. We have additional training on how the body and how the golf swing work together. And as such, I am a very avid golfer myself. This photo is of me down in near the Dallas, Texas area playing at the Tribute golf links. And it's very cool because it is a course combined of a whole bunch of famous holes over in Europe and Scotland and England. This is the 18th hole, which is modeled after the famous 18th hole at St. Andrews. They even have the bridge, which is on the left side of the image. Very, very cool. Instagram account for me, I'm at GolfDocUSA if you want to follow me and learn a bit more about golf injuries myself. Okay, well, let's get into it. So a little bit of anatomy on the cervical spine. And so when we're talking about the cervical spine, we have 7 bones typically, and they're named C1 through C7. So the C1 bone attaches with the base and the bottom of the skull. The C7 bone attaches to the first bone of the thoracic spine, which is where the top of our rib cage is, kind of near our collarbone area. And so we have those bones that stack on top of each other, and we have discs between those bones in the front part of the spine. We also have the facet joints that stack those bones on top of each other on the back part of the spine. In addition, we have a ton of ligament structures that help provide stability to the spine itself. Ligaments all throughout our body, they're basically pieces of duct tape that help hold bones together. And then we also have a lot of small and large muscles that surround the cervical spine, which help provide movement as well as stability, so limiting excess movement. And so the top 5 we're about to get into, it's not necessarily injuries that occur during golf, but what golfers most often experience in the neck that limit their abilities on the course or even to just be able to play at all. Okay, number 1, by far, degenerative disc disease, very common cause of chronic neck pain. There's very high costs associated with symptomatic degenerative disc disease. Surgeries such as discectomies and cervical fusions and all of that certainly rack up the cost associated with pain in the neck itself. And usually, degenerative disc disease is from chronic breakdown. Oftentimes, what I tell patients in person is, congratulations, you've lived long enough to get degenerative disc disease. I'm proud of you. If you live long enough, you will most certainly experience it. But degenerative disc disease can also be exacerbated by traumas such as car accidents, falls, ski accidents, mountain bike, whatever it may be. And so, with degenerative disc disease, those discs can start to protrude backwards towards the spinal cord, as well as the nerves that exit off the spinal cord. And so, in this image that we see here, we see the spine which are the gray blocks that stack on top of each other. Right behind that is this gray tube. That's the spinal cord that runs from the brain, which we can see the very bottom part of the brain here at the top of the screen in this picture. And we see those discs that are starting to degenerate. We see some disc bulges that are sticking out there. We see some dehydration of the discs, so it's losing some of the water content of the discs. And we see some loss of disc height as well. In addition, we also see a very unusual looking curve to the spine. We want to have a nice normal backwards curve when we're looking at the spine. Kind of looks like a little bit of a C shape, but they've certainly lost that. Very, very common in individuals with a history of neck issues. And so in addition with degenerative disc disease, we also have a loss of disc height. And so that will decrease the effective space where the nerve exits off the spinal cord and ultimately will go to its destination. In addition, we can get facet joints that are enlarged and arthritic. That can certainly be a source of pain as well. And we know that there's a significant portion of the population that's never had any neck pain. They're walking around, they have degenerative disc disease, and they don't even know it. That's because they've never had any images done to diagnose it. Why would you get images if you're not having any symptoms associated with something? And as we get older, as we add candles to our birthday cake, the likelihood of having degenerative disc disease goes up and up to the point once you get 60 and beyond, in the vast majority of people, whether you've had symptoms or not, it's pretty much guaranteed that you'll have evidence of some degenerative disc disease. And so other findings include, we already talked about the arthritis of the facet joints. You can get bone spurs or osteophytes, which are just extra pieces of bone that the body's making to try and reinforce an area. We can get instability of the structure of the spine and the stability of the spine. Due to ligaments that get loose, they can no longer stabilize the spine itself. We can also get weak muscles that cannot move the spine properly or help provide that needed stability. And again, like I said, we can get that loss of normal cervical lordosis, or that backwards curve. And some patients can actually start to get a little bit of a forward curve called a kyphotic curve. So their cervical spine starts to look like their thoracic spine, because the thoracic spine does have a nice normal forward kyphotic curve. Okay, next on we go. Number 2, disc herniations. Now, there's a whole lot of nomenclature for this. Bulges, herniations, protrusions. I'm kind of lumping them all in one category in this. And so I want you to think about a disc just like the lumbar spine that we've talked about before. If you haven't seen that one, go back and get a refresher on the lumbar spine video that I did a little while ago. But think about it like a jelly donut that's wrapped inside of an onion. So we have a very compressible jelly donut on the inside. That's the nucleus pulposus. And outside, we have that fibrous layers of the annulus that help provide structure and stability and strength to the disc itself. So that's the lighter blue area versus the darker blue periphery. And so any weakness or injury to that annulus can cause the disc to protrude or herniate out of that weak spot, just like we see here. And it can cause injury or compression to those adjacent nerves, just like we see on this image right here. And you can have disc herniations or protrusions right in the middle, close to midline, far out here on the side, and they can all result in different symptoms and different presentations overall. Okay, and so what happens when those nerves get irritated? Because what are nerves? Nerves are basically information that gets sent up and down to and from the brain and from and to wherever that nerve travels to. And so any irritation to that nerve can cause it to disrupt the signal that's going up and down. And so you can get numbness down the arm into the fingers. And so when I test patients that have neck issues, I'm looking at their shoulders, their elbows, their hands, testing sensation, testing strength, because the problem isn't necessarily with your fingers. If you have numbness in your fingers, the problem's up at the source, typically in the cervical spine. And don't get me wrong, disc herniations are very common, just like degenerative disc disease. Tons of people walking around, tons of people, friends and family members that have disc herniations, and we don't even know it simply because they don't have any symptoms. And so picture right here, this is our orange circle sign that I made there. We have this big piece of disc that's sticking out and most certainly getting in the way and probably causing symptoms going down whatever arm that may be in that patient. But even right above it or right below it, we see these little small protrusions that are taking place. Certainly not to the size of this large one, but it is definitely present. Okay, moving on. Number 3, facet joint osteoarthritis. Remember, we just talked about those facet joints, and they're the joints that stack those bones on top of each other. And just like any joint in our body, they can get angry, they can get arthritic, they can get unstable. And so osteoarthritis is a big, complex disorder that's much more than just loss of cartilage. There's the bone spurs or the osteophytes that can develop. The biochemical environment in a joint gets changed. And so the balance of those proteins, there's only about 700 proteins that are in joint fluid. And so the balance of those proteins gets altered as a result of joint osteoarthritis and instability. And the beautiful thing about the cervical spine is that it's so mobile in a patient without symptoms. We can bend it forward, backward, we can rotate side to side, we can bend left, we can bend right. We can do all of those things together. And so unfortunately, when we get facet osteoarthritis, that can result in limited or painful movement when we put ourselves in particular positions. And so those 7 bones that are in the neck, as well as those above and below it, have to move together in order for us to function properly. That's where that stability comes in. And so instability means those bones stop moving together and one or more are acting independently of the other. And instability is more of a dynamic finding. So sometimes we may order dynamic x-rays, either front to back, side to side, to see how those bones are moving on each other as you actually move. Because on an MRI, sometimes we can see a little bit of static instability if the bones aren't stacked on top of each other properly. But we really need some of that movement to be able to determine the instability that's going on in the cervical spine region. And so this image here is a little bit of a roadmap called facet referral patterns of pain. And so some people can have pain between their shoulder blades, in their upper back. And the problem's not between their shoulder blades or their upper back. They may have some tight muscles. But oftentimes we find that that pain is referred from the cervical spine joints themselves. And so oftentimes we see these findings on images, but those are the latter stages. The biochemical changes have already happened, something we can't see on an image. That's why it's so important to really get down to the nitty gritty and listen to the patient, and they'll tell you everything you need to know. You've just got to listen to them and understand what's going on. And so just like those with ridiculous symptoms going down the arm because they have a herniated disc in their neck, most often the symptoms can come from somewhere else, even though you may feel it in a totally different location. That's why it's important to be with a competent practitioner that is specializes in these areas and knows actually what's going on and how to be able to connect those dots together. Okay, next, number 4, central canal stenosis. So the word stenosis just basically means narrowing. And so central canal is the hole where the spinal cord travels and the nerves exit off the spinal cord on each side at each level. And so the image here, the spinal cord is actually circled in yellow here, and we can see this white that surrounds the spinal cord. And so this is a normal appearing image here for this context. We see the white ring around there. That's called cerebrospinal fluid, or CSF for short. And that's what helps to protect the brain and spinal cord tissue. And then as we get to the middle image, we can start to see we're losing some of that fluid surrounding there. We have less space around the spinal cord, starting to get a little bit of an indent right here in the middle of the spinal cord. And then as we get further along, we see significant change in the shape, some deformity of the spinal cord itself. And so we're not talking about spinal cord injury specifically in this lecture, but if things do get bad enough, we can see damage sometimes in and with the spinal cord. Typically, patients will have some particular symptoms that will give us an indication of that, but that's not always the case. Okay, so central canal stenosis, some symptoms that patients can experience that have this. You can get muscle tightness or soreness into the neck, into the back, arm, hand, etc. Stiffness of the neck, decreased range of motion when you're trying to move, or painful range of motion, popping and cracking in the joints themselves, a weakness or heavy feeling in the arms and the legs. And Dr. Centeno, the founder of our beloved clinic here, as well as the Regenex network of physicians, he's even dealt with symptoms related to cervical stenosis, and he's blogged about this and made it public, so I don't feel bad about talking about it. But he's talked about his experience dealing with this condition previously, and what he dealt with and the symptoms that he experienced and what ultimately he underwent. So now he's able to continue practicing medicine like he has been. All right, number five. Number five, myofascial strain. This is basically a pulled muscle. And so, again, as I mentioned before, we have a ton of muscles that are in and around the neck area. The trapezius, which is our big diamond-shaped muscle. If you've ever seen a bodybuilder, that's what look like softballs right here next to their neck. That's the big trapezius muscle. The levator scapulae, splenius muscle, semispinalis multifidus, rectus capitis posterior, minor, major, obliquus capitis. All of those and a ton more that I won't bore you with today. But all of those can get injured or can get strained as a result of sleeping on the wrong side of the bed, waking up wrong, didn't use your pillow, roll over on the dog. I'm not incriminating myself here, I promise. And waking up with neck pain. Yeah, that's a muscle strain that happens because if you're laying in a position for hours on end, that can certainly cause some temporary changes in the anatomy and strain some of those muscles associated with that. And so there's many layers of musculature in and around the neck, and all it takes is one to create significant pain or spasms in the neck itself. And so just another image here of just all those different muscles that are in and around. And usually something like this improves on its own. Conservative management, do some stretching, do some rest, put some heat on there, etc. Now, if you've got chronically tight muscles, that could indicate something deeper, something underlying, perhaps a structural issue, maybe some instability in the spine, degenerative disc disease, facet-mediated pain, because we know that chronic tightness and spasms really act as the body's protective mechanism to the spine and really everywhere else in the body. And so the body's kind of going in lockdown mode almost in order to help protect things to make sure that they don't get worse. Okay, now we've identified the top 5 commonly seen neck injuries in golfers. What on earth do we do? Okay, so this is what the insiders do. This is what I do. This is what all the experts do. So especially if you're a golfer, you find somebody that is an expert with TPI. And so that way they've had the additional training and education so they can correlate what's going on with your golf swing with what's going on with your body. And so you want to find a physical therapist, a chiropractor, a golf teaching professional that has this certification, and start working with them. TPI experts work with almost all of the top 50 golfers in the world, and there's a reason why the pros go out and seek these experts out, because they're the best at what they do. And now, basic stuff, if you're too heavy, if you're carrying around too much weight since COVID happened, or even before or after, get some of that weight off. Lifestyle modification. If you drink, stop. If you can't stop, cut back. If you're a smoker, please stop. All of those things that we know are bad and aren't helping us and are just further deteriorating our life and our body. Ergonomics with the cervical spine is key. We have so many people that have jobs where we sit in front of a computer all day, and the vast majority of individuals don't have a setup that is ergonomically efficient for them. So alternating between a sitting and standing desk, not leaning down at your cell phone and looking at it like this. That's the worst thing ever for your cervical spine. Make sure you're in an ergonomically correct chair when you're seated, one that has a nice lumbar support, one that has stability. make sure that it's the right height overall for your desk. And so if you've done those things, if you've seen therapy, if you've made all the right changes and you're still not where you want to be, then it would be good to seek out someone that's an expert in orthobiologics, such as platelet rich plasma or bone marrow concentrate. That way you can get the next step, and that helps promote tissue healing and repair. Something that I would avoid are any high dose cortisone or corticosteroid type injections. They're not doing anything to help the healing process, and we know that they can actually accelerate arthritis progression. They can damage tissues if somebody, God forbid, injects a steroid into one of your tendons of your body. And then, of course, surgery is always the last resort. That's how I treat my body. That's what I recommend to my family and close friends. Is I want to make sure that I've done everything in my power non-surgically. And if I'm still not where I want to be, at least I'll go have a conversation with a surgeon and see what options are available to me from a surgical perspective. I promise they're not going to operate that day. All right. So let's get a little bit into bone marrow concentrate. I haven't really talked about this. I've been focusing more on PRP in our previous lectures, but bone marrow concentrate, it's a preparation of cells and healing factors that come from directly from your body. And so where we get our bone marrow from in a patient is usually from the posterior or the back part of the pelvis, kind of that low back SI area right there in the low back. You can feel two bony bumps that's kind of in your low back right above your bottom area. That's the area that we obtain those cells from. And so they also, bone marrow does also contain a small fraction of what we call MSCs. It's an acronym that has traditionally stood for mesenchymal stem cells, but more recently has also been called medicinal signaling cells, mesenchymal stromal cells. And basically these cells operate in the body via what's called a paracrine effect. And so that means it acts as kind of a general contractor of a construction job. And so it organizes and makes sure that the right workers are doing the right jobs. And there's some theory out there that these cells can also differentiate into other types of cells or tissue in the human body, like ligament cells, tendon cells, cartilage cells, for example. But that's not just been proven yet in living humans. There's been some evidence in some lower level animals, but we haven't really seen that in living humans just yet. I don't think the science is there at this point in time, number one. And number two, I certainly don't want people carving out pieces of my cartilage cell, ligament cell, or tendon cell for science purposes, because I'm the one that has to live with my body. And so in addition, there's these growth factors that help boost tissue repair and healing. And we have found over the past 20 years that we've been doing this, that it can help treat musculoskeletal conditions of tendons, ligaments, bones, and joint structures, also neuromusculoskeletal with the nerves as well. All right. Next slide, if we will get to it. Okay, and so one more. All right, here we go. All right, so but I want you to be careful. There's lots of clinics out there that are advertising stem cells and exosomes and Wharton's jelly and umbilical cord products and all this stuff. Not all cellular treatments are the same. You've really got to do some research and do your due diligence, because unfortunately, even in medicine, there are people out there that don't have your best interests in mind. There's too many clinics that don't have the right type of training, that don't have the right safety protocols. Safety is my number 1, 2, and 3 priority. If something's not safe, I'm just not going to do it. There's too many people out there that are doing blind injections without image guidance, not knowing exactly where that's going. And these cells, they don't have a homing beacon to know where to go. We've got to put it exactly into the joint, ligaments, tendons, bones, muscles, whatever it may be. And again, you've got to do your homework. Make sure you see the physician. Make sure they are a trained physician. Make sure they have specialized in this area, because you owe it to yourself to go out and seek the best. Okay, if you saw my last video a few weeks ago, we were top 5 questions to ask your doctor about this kind of stuff. And this is a summary of that. And so how are things prepared? Do they run it through a machine that just spits out something that's supposed to be stem cells or PRP, or do they get it from a vial from dead umbilical tissue or something like that? What's the concentration of it? How many cells are in there? What's the growth factor or platelet concentration? What type of image guidance is used for the injection or for the treatment? which structures are being treated and why are they treating those structures specifically. And you owe it to yourself to get those answers from someone that's competent. What other options are available to you? This isn't the end all be all. This isn't the only treatment option available to patients for pretty much any circumstance. There's always corticosteroid injections or radiofrequency ablation, burning nerves. Of course, surgery is an option in cases as well. And did the physician, number one, what did they train in? Were they a psychiatrist to begin with? And somebody sold them on a course that said, oh, you can start doing stem cells and make a whole bunch of more money and you don't have to do psychiatry anymore. Well, they don't have the adequate training to be able to do that appropriately. And I certainly wouldn't trust myself with anybody like that. And I don't know any other doctor that I work with that would as well. So you want to make sure they've undergone specialized training in orthobiologics. The best would have had a fellowship training specifically in this area and lots of experience with patients. This is all I do. This is all we do here at the Centeno Schultz Clinic. This isn't just a side gig. This is what we have devoted our lives and our careers to, because ultimately we just want the best for our patients. All right. So a little bit about our clinic here at the Centeno Schultz Clinic. We're based in Broomfield, Colorado, one of the northwest suburbs of the Denver region. We've been doing orthobiologics treatments for the past 20 years. We also invented many of the procedures that are used across the world today. We do constant research and evolution here in our clinic. We have two separate labs here. One is directly for our patients that we're treating. The other is strictly for research purposes. And so those are just some of the more recent publications that we published there. All can be found on the Centeno Schultz or Regenx website if you really want to dive into the research that we have published from our clinic. And really all we're trying to do is maximize the body's own ability to help heal itself. This stuff's not fairy dust. It's not magic pixie dust that we can sprinkle on something and make you all better again. We're not going to turn you back into a teenager, but we can help with the symptoms that you have in the majority of cases. There's some patients that I don't feel I can help, but I'm going to try and get you to those people that can, whether that's a surgeon, physical therapy, chiropractic, whatever it may be. And so some of the things we use, bone marrow concentrate, I would say that's the strongest treatment option that we offer for the more moderate to severe cases. Platelet-rich plasma is good for more mild to moderate symptoms and cases. And then prolotherapy for a little bit of ligament laxity, tendinopathy, some joint irritation, some mild degenerative changes. Utilized for that. And they're not isolated from one another. Oftentimes in a treatment regimen, we'll use a combination of all three of those things, depending on what's going on and depending on the patient's specifically, because you are you. You're not anybody else. There's no cookbook for this that says this is the cervical spine page. This is what we do. I wish my job would be a lot easier and I'd be able to see and treat a lot more patients. But it takes the time to talk to the patient, to examine the patient, to look at their records, look at their imaging, to really know what the heck's going on and give the patient the best plan to give them the best opportunity for healing to take place. Okay, just some final thoughts. The golf swing itself, it's complex, it's individualized. Just like our body, everybody has a different golf swing. Nobody swings the same. And I've seen thousands and thousands and thousands of golfers throughout my life and career in playing. And so you as a patient, you need a specialized evaluation. You need a plan that's dedicated to you specifically. And we start at step one. We start with the conservative modalities and we work our way up from there as we need to. If we get to a point where you're at a good place, then we stop. We don't have to go any further. And it's all about continued progress. We want to make strides to get better and improve. We're not going to seek out perfection on day one. In the vast majority of cases, I think that's quite unrealistic, but it's about gradually improving, gradually getting better. Nobody that starts training for a marathon starts running a marathon on their first day. And that's really what we're all about. And so if you have any questions, if you want to learn more, please visit centenoschultz.com or regenx.com. You can always send a message here, shoot me a DM on Instagram, give us a call. Always happy to chat. But until next time, we got our little references slides here. Until next time, I appreciate it. Thank you all. Headed off for a little hike and adventure this weekend. So looking forward to that, but I don't want to spoil the surprise. But everybody take care. Have a wonderful day. Thank you. Bye.